Thanks, Laura. And thank all of you for coming this morning to listen to more information around policy. Before I start, I'd just like to get a temperature. How many of you are familiar with the Markle Common Framework? Okay. In terms of what I want to talk about today, and I'm going to go pretty quickly. You have the slides on your flash drive, so if you need for reference, you can go back to them. But I want to spend as much time at the end as we can for discussion and Q&A. So if there's something I mentioned and you want to know more about it, jot it down and we'll cover it in the Q&A. But I'm going to try and do this quickly so that we can get to the meat of it, which would be discussion. As Laura said, the Markle Common Framework policies and practice were developed really to inform and help make the Common Framework actionable. And that's not to say it wasn't before. In my opinion, I've been working with it since 2005, 2006, and I have found it personally as a great resource to help develop those policies. But over the years, what I've heard through conversations with some of you and others around the country, as has Markle, is that, okay, I can read this, and I know what I need to do, but I'm missing something in between. And that's what these documents were really there to help with. So why now? Well, I think it's pretty obvious. We've never seen this level of HIE or HIT, ever. And isn't it fabulous for those of us that have been trying to push it for so long? We finally have everybody moving in the, at least generally, same direction. And so Markle wanted to provide more assistance to that. And I think the other thing is that the provider side of all of the equation has really evolved as well. It was at one time in 2004 when I got into health information exchange, people would say, oh, doctors, they'll fax. They might email. And we used to look at statistics at how many doctors actually looked at the internet for their stock portfolio. That was the measure that people would give you to say, this is why a doctor will use the internet for clinical care. That's not true anymore, and I think we can sort of pass that over. Now we're looking at statistics of actual use of EHRs and creating conversation electronically between providers for patient care. So we've moved into a whole new era, thankfully. What we did is at Markle, we had conversations with many, many people. State level government, federal government, state government, also users of health information exchange, EHRs. We probably did 50 hours worth of phone interviews. We did surveys, and then we also created an HIE advisory committee, and Will Ross, shout out to him who was here, Claudia Williams was on it, and several of you in the room may also have been on it. But we had a large number of users, and this is small print, you can look it up, but we had a lot of people who helped us develop these documents. We also engaged subject matter experts to help us craft them, and I need to give you the declaration right now that I was not the subject matter expert for any one of these documents. I just herded the cats and managed the process, and actually came at it as a user as opposed to an expert. Here's a list of the policies in practice, and I'm going to quickly go over some of them. We do provide everybody with an overview, so if you've never been exposed to the Markle Common Framework, I would suggest you go there first, because it gives you an idea of where all the documents are, both the Common Framework that was published in 2006 and then the policies in practice. And then we've also included a frequently asked questions, because we found there was the same questions coming up over and over and over again. All the documents are hyperlinked when you get on the internet, and so it's also we've tried to make it as user-friendly as possible. Couple key premises. One, Markle believes, and I support this belief completely, is that a set of clear and explicit health goals is essential for any health information sharing effort. If we are doing this to check a box, it is the wrong reason. And if you're focused on technology and frankly on policy to get it done, you've lost sight of what you're trying to accomplish. And so making sure that those health goals are front and center is key to this whole process. If you're sharing health information, that does not equate to complete health information. So at no time do we ever assume that a patient's complete information is moving through a sharing effort. It may be key information, or it may be all of it. We don't make the assumption to quantity. We do make an assumption in hope of quality. The policies in practice are an adjunct to the original Markle framework. They are not a replacement. So if you just read these policies in practice, I like to hope that they will help you. But if you really want to truly understand, you need to use the hyperlinks to go back to the original source documents so that you are, in fact, getting the full picture. And then lastly, these are not meant to be a toolkit. They are not a how-to. So if you're looking for a process, a flow chart, if you're looking for step 1, step 2, we've done some of that. But we've also left it up to you to decide what you need to do first. So there's a lot of questions, I would say, in the document. Answer this question, and then here's how you might want to approach it. It's not really set up that way, but if you have that framework in mind when you approach these documents, it helps. The first one that we heard a lot of energy around is, how do I keep track of what's going on legally at the federal level? And so we engaged an attorney out of the New York area to help us draft, her name was Linda Malik, Key Laws and Regulations, Changes Relevant to the Markle Common Framework. And essentially what Linda did in this document, with, again, the input of all of those folks that I flashed really quickly, was define the new business associate obligations, talked about the enhanced penalties, new breach rules as we have them right now, and then additional restrictions on PHI. The document is a point in time. So as things change, we do expect to update this document to at least allow for a refresh. But the thing that we heard from a lot of folks is that we need one place to at least see where all the other issues are. And so we don't just address high tech, we also address the stuff about the FTC and OCR and what's changed in those areas as well. So it's in high tech, but we go beyond HHS and looking at that. We do not, and never in the framework will we, address state laws and what the discrepancies are. If you approach the framework, we assume you know your own state's laws and that you will follow those laws. So this does not in any way, shape, or form address what might be happening at the state level. Then there's consent. So before I even start, I have scars on my back trying to reconcile consent. And I would be happy in the Q&A to talk a little bit about that. But I need to give credit to Devin McGraw, who really took the time to think through how she would recommend consent be considered. And the thing I would tell you, and the message she would want me to give you, is that consent needs to be done in context. It is not about opt-in, opt-out. I do understand that eventually we're going to have to use those terms in that conversation when we talk about consent. But this policy and practice was not designed to help you understand how to be an opt-in, opt-out state, community, HIE. It was really to help organizations and or people involved in health information sharing efforts understand what they need to do in order to approach consent. So things like answering the question first, who can access the information and for what purposes? What security practices are in place, and how are data holders held accountable for data stewardship? So it is not meant to be the end-all be-all. It is to say this is in context. If you haven't answered these 3 questions, you're going to have a very, very long, I would submit, non-productive conversation about opt-in, opt-out. This is one document where we did at least try to give you some guidelines as to how to approach it in the order. And she and Devin came up with the HI Advisory Committee's support, a 3-step sequencing of decisions. So initiate policy setting processes based on sound governance principles. Develop a fundamental policy based on Markle Connecting for Health privacy principles, and address the principles of individual participation control and openness and transparency in determining policies with respect to consent. In other words, if you start with consent right off the bat, you're not going to get very far. Once you've done that, then you also need to consider, what is the choice of meaningful? What granularity of choice do you offer? Layered consent could be helpful as an approach, and then how do you approach patient-mediated exchange? So the document addresses all of those different areas and hopefully will provide some guidance to the chaos that does exist around this particular topic. The next principle or policy and practice is on individual access. And who in here has heard of the blue button? Okay. So this principle or this policy and practice actually builds on that principle. And Markle feels very strongly that individuals should have access and control to their personal health information or protected health information. They also think it's a good idea now because high-tech established the individual's right to obtain that electronic copy of their information that's held in the EHR. Patient access and engagement is part of meaningful use. Patient engagement is a focus of ACOs, and I would submit critical if you're attempting an ACO strategy. Health information sharing efforts can help providers and hospitals fulfill meaningful use and health reform requirements. These were the also and nice to haves, but that is actually what drove more clarification in the policies and practice around individual access. As a starting point, we do start with providing download capability, and then have some basic requirements that you would want to have in place in order to provide individuals access. The next one is around governance. And what we found was that governance has taken on a whole new meaning. It used to be, and used to be isn't that long ago, you formed a not-for-profit organization, you finally got through the IRS 501c3 application, and boom, you're ready to go. That's actually not really working very well. In some cases, it's working very well, and in other cases, there are other ways to establish governance around health information exchange. And so this document is agnostic in terms of what kind of organization it is. And we stay very careful and don't use HIE as a noun or a verb most of the time. We talk about health information sharing efforts and what types of governance, and I would say that's governance with a lowercase g, needs to be in place. And so we start with what is governance and what isn't governance. We also provide some examples around how you might approach this. And we have all of our policies and practice have case studies in them and different ways that you can see all of this work actually in practice. We did try to document it with real experience as opposed to theoretically believing this was the right thing to do. Another thing we heard from the community at large across the country was that this is all well and good, and we get that policy and technology should go hand in hand and that policy should drive technology, but has anybody told the vendors that? We did have vendors who participated on our advisory committee, so I want to be clear that the vendors, when we talked with them, said, okay, we get it, policy and technology go to hand in hand and policy should drive technology. But why isn't anybody talking to us about what that means to them? And so this policy and practice was really developed to help that conversation, both from the HIE side and what the responsibilities are there, but also what the responsibilities are for the vendor. And it is based on these 9 principles. And so we give, again, real tangible examples of how you might approach this, starting from the RFP process, contracting process, and my favorite is we sign the contract and what we wish we knew this now, how you might approach that conversation as well. Coming soon, and it's not on your flash drive, unfortunately. Will and I tried very hard to get it on the flash drive, but it's still in production, and that is the model contract. And how many of you are familiar with the model contract, Markle's model contract? Okay, a few of you. So when I use this word, data sharing agreement, what is that? Anybody, does that resonate with anybody? Does it make anybody just want to jump out of their skin? Okay, the model contract does in fact provide what I call negotiation points or discussion points for anybody that's going to do health information sharing. We've revised it to be more meaningful in the current environment legally, and based on experience, we've actually added more information about things you might want to discuss. I was one of the first to ever use the model contract in 2006 in the Memphis Health Information Exchange. And what I've said repeatedly and would say to you now, it is not a contract you adopt lock, stock, and barrel. It doesn't work that way. It will get you and your community, however you define it, 50 to 80% of the way that you need to in terms of addressing those particular issues around exchange. It is really and truly a relic or an artifact of trust, because when we start all this, we have to have, most people will want something in writing. This helps you address most of what you need to address in writing. Not all of it, nor does it address any state laws, as I said before. So look for that to be coming soon. If you want additional information, this is the Markle website. Laura Balin is, right now, she's leading this effort for Markle. And if you want to stay informed, you can get on their listserv at this email address right here. If you'll email them, they'll email you whenever anything new comes out. And when we get to the end, I'd be happy to take questions, and we can have a discussion if you'd like around this.